from 200 individual that presented to the emergency department over a period of 6 months in 2002. So we saw them 6 months later and compared their Bartel index with pre-fall levels and found that across the board, they had become more disabled just 6 months after an index 4 presenting to the emergency department. And then when we looked at their mortality rates, what we found was that within a year of actually presenting with an index 4 to the emergency department, 20% were no longer alive. Now, this statistics is as stark as hip fracture. So they don't actually need to have had a hip fracture. They just needed to have fallen in order to have such a scary mortality rate. And when we followed them up for 10 years, only 20% were still alive. So to be honest, these kind of statistics is worse than cancer nowadays. So we then embarked on a randomized controlled trial, really looking at a pragmatic approach towards delivering individually tailored multi-component interventions in our older folks compared to what they would normally get with conventional treatment. So they might still get interventions, but it will not be under the trial if they were randomized to control. So we recruited individuals over the age of 65 who have had 2 or more falls in the past year or 1 injurious fall in the past year. And then we actually randomized them to individually tailored 6-component intervention, which includes the Otago exercises, home hazards assessment, cardiovascular assessment and intervention, visual assessment and intervention, medication review, and also medication deprescribing, and everybody got falls education. In the control arm, they would be given health advice, nothing to do with falls education, and then they will be left to the conventional treatment. And then we followed them up over a period of 12 months using falls diaries. And we also complemented this with a visit at a year, but many of them didn't come back anymore because they were more disabled. So the diaries were far more valuable. Okay, so when we looked at this, this intervention study, initially we just counted the number of risk factors per person. And we were a little bit surprised to find that out of the 264 individuals recruited to this RCT, falls risk increasing drugs, medications was actually the most common risk factor among all our participants. So because falls are multifactorial, when you added up all these risk factors, it comes up to a few 100%. So, and traditionally, we always thought 9 out of 10 of people with falls would have gait and balance problems, but we only detected gait and balance problems in 60% of our participants. This is lower than what international published studies have suggested. And we also did a very sensitive blood pressure tests, which used beat-to-beat blood pressure monitoring, and we found orthostatic hypotension in 60%. This might actually be reflected in the fact that a lot of our fallers are actually actually have drug-induced falls, and one of the main mechanisms for drug-induced falls is actually orthostatic hypotension. Home hazards, 1 in 3, visual impairment, 1 in 4, and there's this condition called vasovagal syncope, which is actually the common faint that we diagnose using a tilt table tests, actually occurred in nearly 1 in 4. And this is a surprise, but again, we wouldn't be surprised because we're a very hot country. And so, you know, people fainting and forgetting that they fainted, but telling people they've fallen instead is perhaps quite a common occurrence in our population. So there's also poor footwear, osteoarthritis, foot problems, which are all neglected issues. So traditionally, we've always thought falls equals stroke, and it's right down there. Only 3% of our participants have actually ever had a stroke. None of them actually had a stroke at the time of the fall. They already had a stroke and then they fell because of weakness from the stroke. Okay, so when we looked at medications and falls, this challenged traditional belief that antihypertensives were actually associated with increased risk of falls. So all the medication published studies on medications are actually quite historical now. And we all know that antihypertensives that we prescribe now are not like antihypertensives of yesteryears. There are far, far fewer side effects. A2R, angiotensin II receptor and agonists, for instance, have fewer side effects than placebo. So it might come as a surprise to many of the falls physicians in that no matter how we looked at it, we couldn't actually find a significant association between antihypertensive and falls in our population. But then we looked at these drugs called falls risk increasing drugs. So what this slide suggests is that traditionally we also say if you take too many medications, then you're more likely to fall. But what we found was that actually you're only more likely to fall if among your many medications that you were taking, you were actually taking what we called falls risk increasing drugs. So if you were not taking falls risk increasing drugs and you had polypharmacy, then you didn't, there was actually no significant increase in risk of falls in that group. So what we really need to be looking at in fallers is this thing called falls risk increasing drugs. And the list is actually in the published literature. Okay. So we moved on because we found that blood pressure was actually quite a prominent risk factor amongst our fallers. And then maybe we said the cutoff for orthostatic hypotension perhaps is just too liberal for our population or for the older population. And indeed, when we looked at the cutoff of 20 to 10, even among non-fallers, 57 actually fulfilled the criteria for 20 systolic drop and 10 diastolic drop in blood pressure. And then so we tried to play around with the cutoff for orthostatic hypotension. And what we found is that just by looking at systolic drop of 30 or more actually improved the sensitivity and specificity. So we are now on a mission to work with the international fraternity to try and refine the definition of orthostatic hypotension. And this is our work on osteoarthritis and falls. So osteoarthritis is a totally neglected area in this part of the world, but also quite neglected area worldwide when it comes to degenerative disorders affecting older people. We tend to only think about we tend to only think about dementia when it comes to degenerative disorders. And we actually found that overall, if you looked at osteoarthritis as a whole, there was no significant association between osteoarthritis and falls. So we measured the symptom severity of osteoarthritis using the WOMAC score. And then when we looked at patients with radiological evidence of osteoarthritis, those with mild osteoarthritis, in fact, were less likely to fall. But then when we looked at people with clinical symptoms of osteoarthritis, that means that they had pain, impaired mobility, and also the crepitation when we examined them physically, then it was only those with severe osteoarthritis that was actually more likely to fall. So this is actually something very new in the international literature, and now we're working on trying to understand a bit more about this bidirectional relationship between osteoarthritis and falls. So you do want to know what my fate show, and we were a little bit sad, but we were not surprised. So this was a pragmatic RCT, and even with the best intention in the world, we could not deliver the interventions in a timely fashion because of our healthcare system. People would wait 6 months before they have their cataract operation. They would wait, they would take a year before they actually have their home hazards assessments. And therefore, when we followed them up over a year, when we looked at fall recurrence, there was no significant difference between intervention and control. If with an eye of faith, if we had a bigger sample and we carried on for longer, the lines might be separating and we might actually see a very small effect in fall recurrence when it comes to our cohort. But this was much, much more interesting. So the Otago exercises we could deliver immediately because exercise intervention, you don't have to wait for the physio. Our physiotherapy, our researchers could teach them Otago exercises straight away. And so we followed, this is 6 months follow-up after Otago intervention. And as you can see, time up and go is this walking speed. And basically their walking speed had actually improved after the intervention. Functional reach is how far they're going to reach without falling over. And functional reach, there was a significant, highly significant improvement. And what we found was that we also measured grip strength. If you didn't intervene, the grip strength got worse. And if you intervened, the grip strength stayed the same. So we're challenging now the outcomes when it comes to falls intervention, in that we shouldn't be measuring falls recurrence, but we should be measuring sarcopenia or muscle strength. So this, all this has culminated in the start of a Falls and Syncope service at the University of Malaya Medical Center. This is a rather old slide, I haven't updated it. So we have now got over 1,000 patients in our database, in our registry, and this is some of the work that we've done from the service in demonstrating the overlap between falls and dizziness, and that's published in the Malaysian Journal of Medicine in 2017. Okay, so we also
have to limited time, please.
Okay, so yeah, so this is a video that we developed with the community to try and advertise the fall awareness. Okay, sorry, I won't show the video then. And this is a position statement that we've developed with the Malaysian Society of Geriatric Medicine on falls and fragility fractures based on some of our work. Thank you very much.
Thank you very much, Professor Pin. Sorry to stop your interesting presentation because we just on the entitled time, right?
Yes.
So thank
you very much.
Okay. So now we continue to the third speakers. Maybe the floor assistant can display the curriculum vitae of the third speakers. Okay, the third speaker is a Professor Supa Pengpit. She is a professor Mahidol University, Thailand. She is a professor and head of the Department of Health System Management and Policy at the National School of Public Health, South Africa. Served as the director of Asian Institute for Health Development Mahidol University. So, welcome to the Professor Supa Pengpit. This is your time. Where is the professor? Okay. Why are you not looking here? Okay, thank you. So you can now present Professor Supa Pengpit.
Okay, good morning, everyone. My presentation is not based on my own research as the other two speakers, but it's based on the review because I think maybe when people already talk about the fall incidents or some intervention, I have reviewed the overall of intervention so that we can take it forward, because we know that I think I have only 2 slides that is mention of the fall problems, like the other 2 speakers already elaborate. I'm not going to repeat these parts. But we have to look at the barrier also for the fall prevention, because all of us, we have listened already, when the fall happened, there's a lot of consequences. So according to the review, they said the motivation factors like lack of inner drive or self-denial or some inaccurate prevention and fall perception and fall prevention of the elder itself maybe is the main barrier of fall prevention. And I think since there's a lot of consequences, fall prevention is not only can look at only intervention individually. We will look at in terms of home modification and environmental modification as well. Then the home modification and environmental work is have to do with I want to say is design for the future, because once you already have built a house or you already build a long-term care or hospital or facility, it's difficult to remodify because you have to break, you have to spend a lot of money for doing it. Like tomorrow, I will have another talk with the group of the engineer and the architecture to design the home that people can live when they are young, until when they are old, when no need to remodify again, or you no need to move out to stay in the elderly place because it's already have a long-term plan. Anyway, apart from that, I think the education is a little bit changed a little bit in Thailand, that to prevent fall prevention, there are some talk and training between the architecture and the who are design some certain building and the house, and together link with the medical school, so that the input is will come from multidisciplinary, because now I think we treat fall from the perspective of medical and public health, and construction, the civil engineer or architecture, they design based on their perspective, so it's need integration. So Mahidol University, we have the new discipline of medical student that are going to learn something in aspect of engineer, architecture, IT, information technology and management as well after they graduate, so that they can have the whole perspective of health related designs. Now for the fall intervention, what has worked so far in the past so many years that we're trying to do research in terms of fall screening and prevention. There was one that pop out from the review that is the protocol published last year. They're not published the result yet, it's only protocol, but I think the first one, that is fall risk screening strategies in primary healthcare, I think this paper maybe we should follow if their strategy and instrument that they develop is works. Now when we look at fall, so now we have to see where's people fall, in their house, outside their house, in the community, in the facility with the hospital. Apart from the setting bed, we have to look at a target bed, because who is fall? Healthy people, people who have disease, and people who have stroke. That is different percentage, the different prevalence of falls. So when we come to, I think the second one, they said, okay, the community-based exercise program that is found effective. Why it is? Because when you encourage the elders to exercise alone, maybe it's not so motive for them to really do exercise, but the community-based exercise seems to be much more effective. And the third one is also still related to physical exercise program to prevent fall, that they said it is found significant, that is can reduce the physical exercise can reduce fall risk and also fall risk among healthy adults that is living in the communities. So another review, they said continue physical exercise program, but it's not only one particular program. It's maybe exercise, you have to do balancing exercise, functioning exercise, and resistant exercise, the three things combined together, that is found effective. Tai Chi or some other thing is may, but it's have not so high evidence. And among in Asia, I think is maybe include many other countries in Asia that is have similar result of the similar effective result of the fall exercise. Now we come to the main that I think is difficult to do if we don't have long-term plan or we don't talk with the other people, is about home modification. So home modification alone is also cannot prevent fall. You have to do, they call multifactorial program, that is home evaluation, home modification. You have to have a physical exercise, physical education, vision check, medication, and some other technology that is prevent falls. Apart from home modification, so now we move to environmental assessment and modification, because fall is not only inside the house, it's also outside the house. So I think this one we need a partnership with the community people, and then I think it's also found effective in terms of preventing fall, in terms of environmental assessment and modification, like slippery, like the slope and some other things. The other is they said the intervention for fall prevention among elder people in facility and the hospital. When they said facility, it means like maybe long-term care facility and some other facility like maybe shopping mall or department store or something like that. And then in the hospital, so far they found very little or no different in terms of fall risk prevention, both in facility and in the hospital. But I think in hospital and long-term care in the developed countries, they have a lot of facilities, technology and facility like bed sensor and alarm and sensor. When the elder people walk somewhere outside the building or outside the room, there are already alarm and sensor that is alert for many people. We move to the fall prevention facility. It's continued that maybe after stroke, among stroke patients, because I think this group is the highest risk because of medication and some other physical condition. They still didn't have any intervention that is a full or strong evidence and not reduced number of fallers yet. So I think the intervention among stroke people already have stroke, is need to be considered. In terms of together between home assessment and physical and environmental intervention, I think in some country they already have the law request for all of the facilities and hospital to comply with the falling, but it's still not effective in terms of preventing fall or reduce the injury. But the providing effective home modification, like maybe people who have low vision, you have the lighting, you have contrast in color, like the staircase. When the different staircase you change, you put the ribbon or you put some sticker on the ladder, on the step to make it different color so that people with the poor vision, they can notice very well that they change or they move to the other step. That is also important. And I think the other thing that is need combination with the, when we look at home modification, we have to look at the physical condition and the health status of the elders itself also. And I think the last example is from the Spinal Cord Injury Center in Canada, that they written very good in terms of fall prevention. They have pre-fall, post-fall, and the communication among staff, patient, and the family, because pre-fall is like maybe you identify, you do some risk assessment, and then you manage according to fall prevention strategy. You need to prevent it first, because once they have fall, there's a lot of cause and consequence that has happened. So when they are fall, post-fall policy, they have the recovery, treatment, whatever, the incident reporting, this is important, and also classification. And because the classification is make the future planning and modification possible. And fall prevention and management policy is made different between hospitals. You can't have one size fit all, because if you look at the various type of hospital, physical environment of the hospital, they are so much different. So it's need proper. The third, I think the last slide that is related to fall prevention and management that we have reviewed is that it's need proper communication among the patient, the elder itself, and the community, so that everybody can help each other. Like maybe when we say home modification, the elder doesn't sleep alone, they're staying with the other family members. So we say remove clustering, helping each other, organizing item in the home. So we need collaboration from the family members. So in the review, there are many points that cover in terms of fall prevention. Like, for example, discuss with the doctor, have an eye check every year, check of medication, like the previous speaker have already mentioned. Exercise to increase strength and balance, reduce cluster. This one is not so detailed. The other example is similar, but I think they make it very good, including handrail, unslippery carpet, because there are some carpet that is movable. When people fall, they increase the risk of fall. The preventing fall, like maybe this example, I think the reader or the audience can download and combine or integrate. There are two models that I think very critical that we can maybe translate and use in our ASEAN country. Like this one, the first one is home checklist, like the flooring, the bathroom, the stair, the lighting, and the hard to reach concept. And the second one is about the chair that you have. The detail is can be bedroom organizing, how we do it. This is checklist for home safety checklist that we possible to use. And the other list that I think we can integrate is like maybe senior fall prevention checklist is the whole house of the similar to the previous one, but they add the item of kitchen, because nowadays more and more the senior citizen, they also living alone, or they're living among themselves. So kitchen also another place that is particular, that is always have fall happen or some other accident or injury happen in the kitchen, and also the bathroom. And the other checklist for fall prevention and instrument or some equipment that is preventing some fall, like maybe bedpan or sitting bedpan. The bedpan sometimes is also difficult. There are some like wheelchair and you put bedpan underneath, for example. All of these intervention that is have review, I think is critical that we can combine the successful intervention and we translate and we trying to use it ourselves. So it's cover individual itself for the elders, the household, the environmental checklist. So I think this one, it should be a very comprehensive intervention in the future for fall prevention. Now we look at our maybe Indonesian house, Philippines or Thailand house. Our houses in the Asian style is most likely that if you build it like this in the future, it's also difficult for elder or to have risk for fall prevention. So that's why I think nowadays, from now to the future, when we think about fall prevention, the aging accessibility, when you start building the house, we have to think about it is long term, because you modify afterward is very difficult. And especially Asian house, we have like this, maybe the house that you need to climb staircase, and then how we make the staircase to be very safety for all of the elders, or the house that is a little bit lower like this. But I think building the house that the house and the toilet, Asian houses, you always have the toilet outside somewhere that the elder have to walk from their house to the toilet outside, which is also increasing risk also. So how we make the distance from the house to the toilet that is safe and clear and non-slippery in the event of rain, and so that's why I think I would like to see that maybe among experts that we work together, we treating or we start intervening the fall problem comprehensively from the three side perspective: the person, the environment, and the household, and also the compliance or coordination of family member and community. Thank you so much. That is my last slide.
Thank you very much, Professor Supang Pengpit. It's very interesting material that you have already presented. So the continuance of the scheme is, there's any question from the attendee for this all of the speakers? Oh, okay. There's one from Dipani to Bu Indri. May I know whether the 95% confidence interval for the prevalence of falls overlap with each other for different ethnic groups? It's just only one question. Maybe we can hear answer from the Associate Professor Indri. Please.
Okay, thank you. Actually, I think this question is for Professor Tan, because Professor Tan in slide explained about the prevalence of fall for different ethnic in the Malaysia, because in Malaysia there is many ethnic group.
Yes.
If I'm not wrong. Yeah.
Yes, that's right.
This is for Prof. Tan.
Okay.
Yeah.
Yeah. So the
Okay, maybe it's for the Tan. Okay, Prof.
Yeah.
Professor
So
Tan Mapin, please
it's
answer
very different.
questions.
I think when you looked at the percentages with, because our cohort had 1,500, so the significant level is very, very high. So it's 18% in the ethnic Malays and 24% in the ethnic Indians. So the confidence intervals were really, really very far apart. So yes, there's a very highly significant difference in falls prevalence between ethnicity. And some of this work might actually explain, hopefully, the intercultural differences in fall prevalence. Because I think when you look at internationally published studies, if you look at the Far East, across the board, they seem to be actually looking at a 15% fall prevalence rate. Whereas when you look at studies from the Western countries, you're looking at a 33% falls prevalence rate. So Malaysia sits in between. So maybe some of the ethnic differences can actually be can be used to identify what explains cultural differences in fall prevalence.
Okay, thank you. Is there any questions? Please write down in the chat room. Maybe I can read a summary of brief summary from 3 speakers. Would you mind to display? Helen? Is there's no questions? Okay, please. Okay, Associate Professor Indri said that the IOC score of IFRAD Indonesian Fall Risk Assessment is right on the requirements, that the ability to the test is, I think, is enough, but it's not for the explaining the possibility of a fall, but it still need improvement to adding some factors, because when we are to know that is not strong enough. And Prof. Tan Mapin presented that Otego exercise improved TUG balance measure with the functional research and prevent grip strength getting worse among older fallers in the MIAFE, the Malaysian Fall Assessment in the Intervention Trial Study. Is this correct, Professor Tan Mapin?
Yes, totally. And
okay.
And then the Indonesian problem is that the fracture is not really fully representative of all the risk factors that's relevant to our region. That's why the issue is, and so she's right, we need more factors. And, some of our findings will be useful.
Okay, thank you. And then from the Professor Supa Pengkrit presented fall prevention and management policy. The example included from the documents analysis of spinal cord injury in the Canada Sinks et al. 2020. There's 1, pre-fall policy and procedures. 2, post-fall policy and procedures. And the 3rd, communication between and among staff, patients, and family. I think that's all of the brief summary from the 3 speakers, the amazing 3 speakers. So this big applause for them. I think because there's a mute, so give the raise hand perhaps so they can. Thank you very much. And now I think we can join to go to the main room. Please, you can push the leave room and go back to the main room, because there's still information. I think that's important information for tomorrow. So thank you very much for the speaker, and thank you very much for attendees. Thank you very much, and we are joining again in the main room. Okay, Thank you.
Dear ladies and gentlemen, before we move to the main room, we would like to take a picture.
Okay, good. Please take. I forgot for the message for the pictures.
Please, everyone, open your video.
Yes, please open the video. So we can take the picture. Please open the camera on. Okay, 1, 2, 3. Next to the page. That's yes.
Okay, next slide.
Okay.
Okay, done.
Done. Okay, thank you. See you in the main room.